Let's talk a little bit about neural networks. This is a topic that is particularly relevant to, or it's a big part of the conversation for the EMDR community, but it is, I think, very relevant for all trauma therapists, and it's why I bring it in here. So what we know about a neural network is that it's a group of interconnected neurons in the brain that work together. And they form the basis of all of our learning. Every time we learn a new behavior, we're creating a new neural circuit. Anyone in here, I didn't ask this one before, but anyone in here do neurofeedback? Not in this training. I had a few in the last one. Anyone in here refer to clinicians who do neurofeedback? A few of you. I think this is really, I don't do it myself. I do refer to clinicians who use neurofeedback. I think it's a really great resource that we have out there, and it's really worth considering. Yeah, so neurofeedback is like biofeedback, if you're familiar with that. It's a way of basically learning through feedback of how to train your brain. Sorry, I kind of jumped off of my slide here into another topic, but we'll come back to the slide. So in biofeedback, usually you're using skin conductance or respiratory feedback as a way to know, am I in my sympathetic nervous system, am I in my parasympathetic nervous system, and how do I basically through feedback, through machinery, get feedback that when I breathe a different way, I can change the quality, the state of my nervous system, right? Neurofeedback takes it a step further, where you actually have these node placements that are sensors on your head that are sensing what parts of your brain you're activating. And then you can get feedback based on a computer screen that lets you know that when you're thinking about gratitude, for example, it's lighting up this part of your brain, and it lets you know when you're thinking about your traumatic memory, this other part of the brain gets activated. When you're thinking about the fight that you had with your spouse or the child and so forth. And so you start to get feedback about what's happening internally based on what you're thinking about, how you're breathing, how what you're feeling in your body, and then you get to be more in charge of your internal state using that feedback as information. So it's a way of breaking cycles and learning new pathways, which is going to take us back to our slide. Does that help answer your question? Okay. So every time we practice a new behavior, we get to create a new neural circuit, and then as we repeat that behavior and frequent repetitions, we myelinate these nerve pathways, which allow signals to move more quickly and smoothly. Ultimately, all of our memories are neural networks. So this is a little bit of a sad truth. We cannot erase the neural networks of our traumatic memories. There was some article that I had come across, or maybe I think I actually heard this one on NPR, and it was covering a new medication that was being studied to erase traumatic memories. Do any of you remember this study? It came out, it was maybe 3 or 4 years ago. And I'm listening to the radio. I remember I was standing in my kitchen. It's such a clear memory, and I thought to myself, what? Really? Like, really? You're going to just erase that traumatic memory? And do we even want that? Do we want to just make that experience go away, where we're going to erase that part of ourselves? And it really like had me stop and reflect on that question. My personal conclusion on it, and it's interesting because I've seen very little on this topic since then, so either the medication didn't work or people thought, oh my gosh, this is a really disturbing science, we better stop this, is that I don't think we're meant to. I don't think that we're meant to go and erase what happened. We're meant to accommodate it. We're meant to develop meaning making around it. We're meant to develop new pathways that help us feel strong despite what happened to us. But I don't think we are meant to, and B, maybe we can't even erase the parts of ourselves that hold the memory of what happened. So the downside of that is that when triggers in our environment happen, individuals who've been traumatized, especially repeatedly traumatized during early development, are typically going to be susceptible to going back to that vulnerable place. The upside of it is it doesn't mean that we're bound to be stuck in repeating it, because what we can do is develop new neural pathways. Right? And so even though we can't get rid of the old, we can create new alternative paths. And I often think of this, look, if you're walking on a path through the woods, right, and you've got that well-worn path, the one that you've always taken, and you've got another option here, but the first time that you're going to walk that new path, you're going to be bushwhacking. It's going to be hard work. You're going to have to work hard to clear out to clear out all the obstacles and the barriers and finding that new path. And you're going to keep thinking to yourself, well, isn't it just easier to go where I know, right? Isn't it just easier to walk that familiar path? And so the hard work of developing that new pathway the first time, of what would it be like to actually not go down the road of reacting and getting angry at my spouse? What would it be like to not go down the road of telling myself that I'm worthless and shouldn't be alive? What would it be like to not go down the road of self-harming or cutting, right? And to do something different this time. And the first time it might be uncomfortable. The second time it gets a little bit easier. And every time you repeat the new pathway, it gets easier, clearer, and eventually I believe that we can make it stronger, more habitual to go to the new neural pathway than to resort to the familiar and the old. Please.
So, if you think of someone with psychopathy or they have no empathy for someone else's trauma or trauma.
Right.
So is it the memory of a traumatic event that someone's experienced, or is it the emotion that memory evokes? Like if they have a memory of it, but they have no emotion about it whatsoever. It's just flat. It's the trauma that it evokes, which is really connected, it's hooked to an emotion, right?
Yeah.
And you can regulate your emotions, right?
Right. Your question's a bit complex, and yes.
Yeah, I'm just saying.
Yes.
It's really the emotion more than the memory. You're talking about, well, do we want to get rid of emotion? Lose that, but you can lose this significant emotion.
Right. Really, what we're talking about is the level of reactivity to the memory. Yes, and so just to repeat this for the listeners online, that the neural pathway of the traumatic memory is still going to be there, but what can happen is that as we turn toward what was, it can be less effectively loaded, right? It can be lead us. We might not have as much of a drive or desire to jump from that into action or into an emotional response from it, right? And that the new neural pathway in a way says, oh, that happened, it's over, I'm here now, these are the things that I can do, that I can take care of myself now, I can make new choices now that weren't available to me then. Back then, I couldn't talk to anybody, I was totally isolated and alone with what I experienced. Now I have you to talk to, and I have other people that I can talk to about this. But the more that I've reviewed it, it doesn't stir up all of those feelings anymore. I feel more grounded. So I can make a distinction between what was and what is. Please.
Have you seen the research of science behind brain plasticity and how many times that new neural pathway needs to be traveled for it to become smooth and habitual versus the old pathway?
I don't know the answer to that. The question is the research about neuroplasticity and how many times a new pathway needs to be repeated before it becomes easier and smoother. I honestly, again, this is not a research-based answer. I honestly think that it really depends on the individual. I have had people that again, just come in with a bit more resource than others, and they find that new experience, and they're off to the races with it. It's like an epiphany. It's that aha moment, and I don't want to lose it, and I want to hang on to it. I'm going to go home. I'm going to write about that new experience. I'm going to tell my partner about that new experience, and boy, what's happening in that? They are kind of naturally reinforcing that new pathway. And there are people who I kind of feel, you guys see that movie Groundhog Day? Right? Like I feel like we have that same session several times before the new experience anchors.
So do you think with your clients, do you think it's a difference between their intentionality?
No. I think it's a difference between how much resource they come in with. It's because intentionality in some way would hold that they're doing something wrong, and I don't think it's that at all. And I just see it as a matter of how much resource does someone have to allow them to access that positive state more easily on their own. Yeah, thank you.
Also what they have surrounding them at the time.
Good point. And also the level of resources, external resources that are around the person at the time that help them have a sense of hope. Right? I have this gal, I provide consultation for her and for her therapist. I don't work with her directly, and she had contacted me this past week, and she said, oh, well, you can use me as an example in your talk, Dr. Schwartz. I said, okay. And she said, tell them that, that there are some people who just continue to have a really, really hard time, but they know that they can still walk forward anyway, and that they can still make a pretty good life, and that they can still do some really cool things. She's a bike racer, and she does some really cool things, and she came from a really tough background, and what she meant by that is that she still wakes up every day feeling depressed. Every day of her life she wakes up and she goes, oh, there's that depression again. And then she says, well, am I going to get out there and am I going to go ride my bike today? And she does. And she does ride her bike, and it helps her feel a little bit better, and it's temporary, and she goes back to bed, and it's kind of like Sisyphus waking up in the morning having to push the rock up the mountain. And that is her life. But she has come to the conclusion that before therapy, there were many days that she didn't want to get on her bike. And she didn't. After therapy, there are days that she doesn't want to get on her bike, and she does. Okay. So I'll tell her that she got to be an example. It'll make her really happy. All right. Where did I put my clicker? Here. So when we're looking at integration of neural networks, that some of this is really across left and right hemispheres of the brain and help us express feelings with words and assimilate positive resources into negative perceptions of emotions. So I think this is kind of a fun picture on here. It's a little too extreme, but often what we recognize is that the resources are held in part of the brain and the trauma is held in another part of the brain. And I often describe to my clients that part of our job is to create a bridge so that they are not stuck in the trauma part of the brain without access to their resources. And if we now think about that research on the corpus callosum, we're building a bridge right across left and right sides of the brain. We want to build a bridge so that they can go, oh, yeah, that hard thing happened to me, but there are these people that really helped me through it. And yeah, sometimes I feel really depressed, but oh wow, I can still get on my bike or whatever it is, right? So that they have access. And it's so interesting. I was doing an EMDR session with someone recently, and he came into the room with a lot of resources. He had been sexually abused as a child. He then became a perpetrator, which was a very hard part of his story, and came into therapy, but this was all years later, and he had done a lot of really deep work on himself, including a lot of spiritual work, and we were processing the trauma of what happened to him, and at one point, kind of suddenly he said, oh, well, my archangel's in the room. So, okay, great. And the archangel comes in and kind of helps him work through the trauma, and he kind of processes that one through. And then we're working through another part of the trauma, and he says, oh, well, Kuan Yin's in the room. Okay, right? And these resources just kept coming into the room and helping him work through what were those stuck points. And it was so remarkable how he kept building that bridge between the really difficult parts of his history and these traumatic and these positive resource states. And then, part of the work is ultimately to go back and turn toward what was, and not feel kind of taken down by it. Feel ultimately that you can see that, and that you can be okay. And that was really where he had come to. Another process of neural integration is between the upper and lower centers of the brain, so that we can manage impulses and develop greater self-control. So we will take a break here in just a minute, but I'll just name this last slide here, that our neural networks in trauma treatment is that our traumatic memories can be thought of as impaired coding in neural networks. That comes from Francine Shapiro and her work with EMDR therapy. Traumatic memories are not integrated with positive experiences. They're limited in their ability to accommodate new information. During trauma treatment, we reactivate neural networks of traumatic events to offer a reparative experience that can facilitate integration throughout the brain and the body. And importantly here, neuroplasticity continues throughout the lifespan. So we get to talk for the second half of the afternoon and all day tomorrow about the implications for therapy that all of this information has. Because the most important thing that I hope that you get to take away from these 2 days is the ability to make practical all of this information, so that you have some real skills and interventions and tools that you can bring into your practices right away. So when we are treating complex PTSD, we are aiming to increase the client's capacity to stay present and effectively respond to or regulate the states of mind, the emotions, the sensations, and interpersonal experiences that are in their daily lives. We are helping clients develop tolerance for uncertainty, ambiguity, disappointment and loss, conflict and compromise, difference, competing needs and desires, and conflicting ideas and emotions. Right? So an individual can hold that they have needs for closeness and that they have needs for space and distance. Right? They can hold that you and I are not the same, that I can tolerate that you think, feel, or believe something different than me. So in a way, we're doing like world work in our private space with individuals. Because what we're seeing right here on this page is the basis of what is a lot of conflict out in the world, isn't it? The goals of treatment is that the client is able to say, the trauma happened to me, I'm aware of the past and how it affects me in the present. The past is differentiated from the present, it's over. I can be mindful of the present moment. I can sense and feel my body now. I have choices now about my thoughts, emotions, and behaviors. And I can orient toward the future. Because a lot of individuals, when they come into, whether it's your inpatient or crisis or office, they come in without a sense that there's a future. And that ability to orient toward the future when all you have known is a traumatic past can feel impossible. It can feel impossible. So that's a tremendous outcome of our work. And Babette Rothschild, whose work I mentioned earlier today, she says that loss of control is at the core of PTSD. So an essential component in healing trauma involves helping clients reclaim a sense of control in their lives now. Yeah. Importantly, we'll talk a little bit about what trauma recovery is not. Did you have a question there? Yes.
I have something small to add. Is that okay?
Yes, please.
I was really struck by the story about a mother in Africa, and there was warring tribes and so forth, and there were a group of men coming in to, unfortunately, rape her, harm her in some way, and she hid her children in her house, and unfortunately she was raped, but she didn't experience it as traumatizing because she was able to protect her children. And so I was wondering if you were going to touch on sense of control or even sense of control in the present moment as you shape that memory and how you reprocess it now.
Yeah. So in a way, the example that you're giving of this woman was an example of how control was a resilience factor. Right. So I'll share the example for those that couldn't hear what you said. So the example is a woman in Africa, and I actually recall hearing this story as well, is that there were a group of men that were coming to the village to rape the women, and she hid the children in her house, and even though she was raped, she didn't experience it as traumatic because she was able to protect her children. Am I getting that correctly? And so the question is whether in some way or another how that factor of control can be integrated into treatment as kind of strengthening that sense of resilience as you're reprocessing a memory. And absolutely. Absolutely, and whether that's a sense of now I have control even though I didn't have control then, or giving yourself an experience of discovering where maybe you had more control than you realized, right? Which is not always possible to find. But I think that piece about now can be different from then. And here are the areas that I have control over now, even though I didn't have control then, is a really huge piece of this. And I think it's why experiential work in the mind-body arena is so valuable, because you get these little mini experiments to recognize that how I'm thinking right here in this moment, or how I'm carrying my body, or how I'm breathing makes a difference in how I'm feeling right here and now, and it increases that sense of control in the here and now that can be built into experiences outside of your office. So speaking to, one piece that trauma recovery is that we're not really focused on memory retrieval. That's a really important part of this, that with complex PTSD and developmental trauma, there are more common to have preverbal and nonverbal components of memories. So therefore, a focus on memory retrieval can actually be detrimental, because these memories are not always accessible, or they're more vulnerable to influence. So, trauma recovery is much more about actively distinguishing the past from the present, helping the client recognize that they are at choice about how to respond to current events in an effective manner. And the goal of therapy is really to experience self as resilient. It doesn't mean that we're not going to work with parts of the past, and it also doesn't mean that we're not going to work with the felt experience as it's related to the past, because I think that's an important part of it. But we don't want to go in trying to dig around for something, right? Or the client that comes in and says, well, I have these vague sensations and I wonder if maybe I was sexually abused, that we can work with the sensation, we can work with the wondering, but we don't have to go in with an aim to try and figure out the answer. We can go in with curiosity about the experience, knowing that a wide range of experiences that, anywhere from just really poor boundaries in the family, poor boundaries around sexual energy, poor boundaries around intentionality can lead to very similar feelings to actual physical sexual abuse. And so just holding that kind of open-ended curiosity with the client in their current experience. Or if they have images but they don't know if they're real, work with it like it's a dream. Say, well, we're going to work with those memories. We don't need to know whether or not they're real. That's not the intention here. But boy, there's a lot of sensation, a lot of emotion related to that image, and we'll work with that and see what needs to happen next. And sometimes that's enough. And it's, I think, relieving for the client to not have to know. And sometimes it's frustrating that they may never know. In general, the treatment for complex PTSD follows the same general guidelines for the treatment of post-traumatic stress disorder in general, basic PTSD, which is that we're still going to work with a 3-stage treatment model. This is Judith Herman's work, and again, this is going to be in your Appendix E if you're not seeing it in your handout right here. So, Stage 1 is establishing safety and stability. Stage 2 is processing traumatic material in a well-paced, regulated manner. And Stage 3 is the reintegration of new experiences into identity and relationships. Now, for those of you, because I saw a show of hands before and spoke to a few of you, for those of you that use EMDR and use an 8-phase model, we can still recognize how our 8 phases cross over with these 3 stages, right? So, going a little bit more deeply into Stage 1, stability and safety, here we're going to spend time assessing the developmental and trauma history. All right? We want to understand what is their ACEs, what is their ACE score. We want to understand them in the context of their attachment relationship. We want to identify specific traumatic events that may have happened later in life. We want to name existing resources. We want to name resources that were there during childhood as well. And for for those of you, one of you said that you work for the VA and you work with combat veterans, to ensure that you're also taking that good developmental history as well, because I've certainly had the experience of working with veterans and then also looking at how combat trauma was sitting on top of earlier developmental trauma as well. Do you want to speak to that?
I'm realizing that we have incorporated into the intake assessment a lot of questions that sort of cover races, which I never really connected to, but it does ask about, history of trauma, suicides, family, that sort of thing. So getting that background and then doing a comprehensive military history.
Yes.
Military over and post, just to kind of have a better picture of what they're coming in with.
That's great. That's great. And what would be really powerful, and so I want to repeat what you said, is that within the VA that you have built into your intake questions, questions that are about childhood history and potential ACEs. I have a question for you. Do you know if upon entry into the military, if any of those questions are ever asked? They were not. Uh-huh.
You go through sort of a physical and you take a test for job proficiency. And that might change. That's 20 years.
Yeah, sure. I mean, wouldn't that be such a powerful approach to have a pre-screen that in no way prevents one from entering the military, but says, hey, you might be vulnerable to PTSD given or maybe even not those wording, but you might be vulnerable. Hey, let's get you some support as you come in so that you can be stronger for what you might face here. Yeah, go ahead.
I bet you that they don't, most retired from the military and reserve.
Uh-huh.
And if you think about it, especially in the Army, which is a bulk of people versus aircraft ships, it's based on numbers of people joining. The amount of people that would be deselected for service would put the recruiting for like the Army drop by 20%.
Right.
Select out people, mental health.
Well, absolutely. And that's part of why a lot of folks that are in active duty or reserves don't necessarily seek help from
Yes, I have found that too. So I want to recap a few of these pieces, and we'll come to your question, which is that there are reasons why people are not pre-screened for mental health, which might prevent them from entering the military, which would be a real loss for the military to not have those individuals. And also, on the flip side, people within the military may resist going and seeking out mental health support because they don't want to be, in some way or another, identified as perhaps being vulnerable in that way because it might prevent promotion and so forth. We'll take this question and then you.
So I retired from the military 6 years ago, and the research actually shows that individuals with those ACEs make better soldiers, Marines, airmen, etc. And so if they pre-screen individuals and took those factors out, so we're not going to take you if you have the
Right.
factors, then they would lose really good individuals.
Right.
Because those are the individuals that make the best fighting, that do the best on the front line.
Yes. Yes.
And so that's why they don't pre-screen for that. Because research suggests that, yeah, they are predisposed to PTSD and such things, but individuals that come from families with alcoholism, low STS, etc., are the individuals that make the best.
Yes. So I'll recap that one as well, which is that there's some research out there about individuals who do have ACEs who are, in a way, make better soldiers because of those ACEs. If they grew up in an unstable household or with alcoholism and so forth in the household, that in a way it's kind of primes the pump, if we can say it that way. One more question, and then we'll go on. Yes.
I work for Military One Source, and I see people being deployed or just come back from active duty. The good part about that is like a BAP program, the military could not have any access to any of the information they give them in treatment. That's changed because in the past, for police and for military, the minute they got the information from insurance that they've been seen once by me, they would immediately ask me if they were fit for duty.
Oh, wow. Wow, that's fascinating. Yes. So a change in how the military treats their policy for EAP, for active duty individuals that are seeking out mental health treatment, is that in the past that information would become available for assessment as to fit for duty, and now that information is respected as confidential. That really is a change. What's that?
They can also get help from their spouses and their children.
Yes, and they can get help for spouses and children, which also would, of course, be confidential. Yeah.
Also made psychopharm a legitimate treatment, and that was never allowed in any military service. You would be medically discharged for that. Basically made it where
Yes.
for PTSD, for Afghanistan and stuff, they're allowing veterans to serve as go on psychoactive or psychopharmacology.
So they've both also opened up psychopharmacology as something that's allowable for active duty soldiers. Well, great, thank you. I appreciate the conversation in here. And I imagine you would all agree that there is a lot of complex PTSD from what you're describing and within our veteran population. And so I'm really glad to have several of you in the room that work with that population and or have a history with that population, because I think this is so relevant and important there. And again, to hold that this really, the value of the history taking, truly now with any population as we broaden this conversation back out, and to spend our time doing diagnostic clarification between, is it PTSD, is it complex PTSD, is it DID, or somewhere on that dissociative continuum? Are we working with someone that's got dissociative disorder, NOS? Are there parts and subparts, and do we need to keep that in mind throughout treatment? Are there periods of lapses of time and so forth? And again, you can assess for that using a DES. We'll talk a little bit more about this as we go. You can assess for that using a MID if need be. And in our initial stage of treatment, we are, of course, building our rapport We are focusing on the mindfulness skills and self-regulation and all of the resource building pieces, acceptance and compassion practices, right? Imaginal resources, so things like helping people identify visualization that helps them feel safe, that helps them feel a reference point of calm in the body. Because sometimes clients live so much inside of that unsafe place that they don't even know what safe feels like. And it can take a while to find that. Containment, as I spoke about before, really putting the traumatic material away. Working with somatic resources such as grounding or with the breath. And increasing sensation and affect tolerance. These are all pieces we're actually going to spend more time on, so don't feel like, wait, we didn't cover all of this, Arielle. We're getting there. And interpersonal skills. And identifying parts and personality structure, another part of our stabilization and safety phase here. And then, and again, if you're looking for these slides, they're in your appendix. Stage 2 is trauma processing. This is integrative approach to processing traumatic events. And I put here EMDR therapy, somatic psychology, but some of you might use narrative exposure, some of you might use cognitive processing, some of you might use trauma-focused CBT. I think there's a lot of crossover between these modalities. I think you'll hear it as we go, and you might integrate some more of these other pieces into the work that you do as well. And then with complex PTSD, because something might not be a single incident trauma, when you're processing through the events, you might focus on trauma themes, like if someone was sexually abused over a period of years, you might choose some of the specific memories that represent the totality of that experience, rather than trying to process through every single one, right? And then you might also need to know how to work with what is the felt experience when I don't have a conscious memory of the event, right? Working with someone who kind of knows in her gut, just based on what later experiences of her development was like, that when she was an infant, that she was left in the crib for hours and hours, and that there was really nothing that she could do. She could cry out, she would be left in there kind of dirty and so forth. And so this feeling that she has, even though we're talking 6 months, 9 months of age, she doesn't have a clear memory, but it's a felt experience, and it correlates with what she experienced later when nothing that she did worked to get her needs met. And so working through some of those kind of early themes and how it feels in the body. And identifying some of the chronic negative beliefs about self, and what is it that you would like to believe about yourself. Regulation-based is that we want to prevent flooding from the interoceptive affect and arousal. We want to stay in the window of tolerance. And we want to engage what we call dual awareness strategies. And whether that's dual awareness of being able to stay aware of what's happening inside the body, but simultaneously recognize that I'm safe here in the room now, or dual awareness in the sense of being able to have kind of quote-unquote 1 foot in the past of the traumatic memory and 1 foot firmly rooted in I'm here, present. It's, what is it, October 23rd. I had to think about that for a moment. Exactly, October 23rd, 2018, right? It's Tuesday at 3:09. And so, to really orient to here and now versus that there and then. And our dual awareness allows us to basically get 1 foot into the traumatic material and to feel just enough of the activation to know that we're accessing the neural network, but to not end up with 2 feet in the past. So when working with clients that have dissociative symptoms or somatic sensations that lack explicit memories, we facilitate processing by helping them describe their present moment experience rather than applying a story. So it can look like I'll give an example. I had a gal that came in and she brought in a photograph of herself at the age of 1, and she was in a full body cast. And she had to have multiple surgeries because of a congenital hip disorder that she was born with. And so she had about 4 different surgeries by the time she was 2 years old. And they would have to re-break her pelvis and then recast her and at different stages as she was growing. And so she doesn't have a whole lot of memory of this, but she had the photographs to kind of access it. And so what she did is she brought them in and identified what it felt like in her body when she looked at the pictures. And then we worked with that experience in a very present moment experiences. We worked through the memory of what are you feeling now? What do you think it was like for you? In a way, sometimes we use kind of different techniques, like if you could imagine your today's self going back in time, what do you wish you could say to that, to you then? What do you think you would see in the eyes of your young self? What emotions do you think you were experiencing? Because on top of these early surgeries, there was really an overall feeling of not being held, attuned to, having her inner world really met throughout that time. So that's what we were reclaiming, not just the experience of the surgery. Yeah. So stage 3 is about reintegration. It's about assimilating positive changes into identity. It's working through grief, loss, resentment, regret, working toward acceptance of life as it is. And also working through what we spoke about earlier, some of those secondary gains, attending to the positive advantages that accompany symptoms and interfere with recovery. And this is also recognizing that there are legitimate underlying losses. We'll come back to all of these topics as we go throughout the rest of the presentation, but I just want to kind of highlight them here. We'll also talk in that stage 3 about resilience and post-traumatic growth, because that's also a very real part of our work, and it's a very inspiring part of our work that we don't want to lose sight of. So, assessing for complex PTSD and that stage 1 work. So I'll pause here for a moment with a brief story. This is actually about a man who was a veteran. He was also, after he left the military, became a policeman, and because of his tremendous capacity to rise up and meet the challenges ahead of him, was put on the toughest force. He was going out kind of frontline work with a lot of gang members, a lot of gun violence, and ended up having several episodes of dissociation that that sent him to be on leave and eventually to be discharged from service. And the dissociative episodes he did not have memory for, but was caught on tape in which he had become aggressive and violent towards some of the individuals, not on the force, but some of the individuals that he was going out to work with. And so he came in for therapy, and we were doing a history taking, and nothing, early childhood, everything was fine, right? Because that was the front end report of it. And so we're continuing to look at the accumulation of stress. He did have a very significant event that happened in Iraq, and then he had some very significant events that happened while he was on the police force. And so we were addressing those specific traumatic events, but as we were doing the history taking, there was something in my body that kept speeding up, and I couldn't quite put my finger on it, but we're doing history taking, and at some point he was talking about his early childhood, which was fine, and my heart rate was racing. And I'm going, okay, well, is this just me? Right? Is this him? What is this about? Why is my body responding this way? And so I kind of let it happen the first few times. About the third time it happened, I said, you know what? I need to stop right here. I said, something's happening in me that I'm just so curious about. And I said, all of a sudden, I just feel like I'm on a roller coaster and we're going up the hill and I'm just waiting to go down the other side. And he goes, how did you know? And he had biceps like this. And he goes, look. And he had goosebumps up and down his arms. And he said, that's how I feel. And I said, well, gosh, I'm kind of glad that we paused there. And I said, well, let's really pay attention to this. And so we're starting to try and unpack a little bit more about this, very normal childhood. And I said, well, tell me about the first year of life, because everything that he could remember later on, he told me how he fought a lot as a teenager. He was out there on the streets fighting, that he had really bought into the sense of his self in the military, the sense of self as a soldier, that whole process was really a very core part of his identity. And so we backed it up, and I said, tell me about, this is kind of strange, but tell me about the first year of your life. What do you know about your parents' marriage? What do you know about that time? And everything was fine. And they said, well, my grandfather died when I was just a few weeks old. And I said, wow, how do you think that impacted your mom? Because here she is with a newborn, and it was her father, and her father just died. And all of a sudden he looks at me and goes, and I died too. What? He goes, yeah, I had a SIDS death, and they rushed me to the hospital, and they brought me back to life. And there it was. And it was an early imprinted memory that was this dual loss, right? And it was so striking how that feeling in my body kept indicating there's something else there, there's something else there. Now, we're talking the first month of life, a time period where, what is it that we're working with? It's not here. It's not a conscious for the most part, this guy said, I really like my life. He's married. He's got this wonderful daughter. He was really disappointed to be discharged from the force. He really liked the life that he was living. He loved his work. And something was trying to find its way and was repeating, and then ultimately was repeating with these experiences of a loss of consciousness. So getting down underneath to this very primal imprint of a period in which he died and came back. And then he had a good relationship with his mom. I said, between sessions, go ask your mom more about that experience. And he came back. He had a whole narrative about that experience, and we were able to work with that. Ultimately, he decided that he wanted to go in a different direction in his work, but the dissociation stopped. Yeah. So, so I share this example because going back to our Columbo detective mode, we want to be very savvy in our history taking. And so we want to look at a very broad, this goes beyond the ACEs here, this list of, and this is again in your appendix, list of developmental trauma events, of what else might be in there that maybe didn't get picked up before, because a lot of people come in for therapy, and they've been in, especially people with complex trauma, they've been in therapy for a long time, and so sometimes just something was just never picked up before. And so maybe there's postpartum depression in mom that might have had a very significant, somebody tell me which appendix is this in? See, thank you. I'll write this down here. So looking at the impact of a mother that had postpartum depression, and this was another one where a photograph was really helpful. This was an adult man, and he came in with a photograph that he had from his childhood, and his mother is holding him, and he knew that his mom had had postpartum depression. That was something a story that he had been told, but in this photo, the mother's body is kind of collapsed, and she's looking away. And he's in her arms, and that photo was so evocative of the lack of attunement, of the feeling of no matter what he did, no matter how good a baby he was not going to get mommy's attention. And so therein, again, a way into that really early memory system. The experience of an extended separation after birth, so being in an incubator, being premature, and again, this doesn't mean that the whole childhood was traumatic, but to work with some of those early layers, because sometimes that can be for several months, depending on medical complications or preterm birth. The experience of adoption-related concerns, being rejected by mother or father, having other medical complications, neglect, abuse, right? We've been speaking about some of that. A parent with PTSD, so looking at that transgenerational layer here. Having a narcissistic parent, a need to perform, for example. Lack of nurturing, competition among siblings, a feeling of deficiency of resources within the family system. Feeling chronically not understood, we've spoken about. Chronic power struggles in the family. An experience of lack of emotional safety, lack of boundaries, the ability, that not being really allowed to differentiate. This would obviously be later in development, right? You have to remain part of me, goes along with some of the narcissism up above. And chronically discounted, chronically shamed in the family. So other kind of inquiry, and I don't necessarily sit down with a new client and ask them all of these questions, because that can be overwhelming. But what I will say is that these are the kinds of questions that I'm holding in my mind, and sometimes I'll ask these questions slowly over time so that we start to get to know what was the experience of the early childhood? Who in your family took care of you? How were your emotions handled when you felt sad or afraid? What were the stories that you were told? And so we're gathering this information, and depending on the individual, we might handle one question in a session because one question opens up the whole can of worms, right? Or we might get through many of these questions. We might ask one question and they're dissociating right there and then, and we say, okay, well, that's enough. We're going to be resourcing the rest of the session. The other thing that I'll say about the stages of healing in complex PTSD is they're not linear, right? We might start out with stabilization. We might move towards some trauma reprocessing. Then we have to go back to stabilization. We might move through and do some grieving, and we might go back to trauma processing. So we honor that there's a fluidity to this work and that it's not all protocol based, right? And we're also looking in these early childhood development questions about resilience factors. So this next slide is adapted from the trauma history questionnaire, and it's just a kind of a more broad sense of what might be some single incident traumatic events that happened usually after childhood, but not always, and understanding if a client has been through a situation, for example, where they were seriously injured or feared that they were going to be killed. I have worked with not just the one individual that I spoke about with the near-death experience, but multiple clients with near-death experiences, and there really is a very important piece about knowing if that is an experience that someone had, because there's a level of conditioning in the nervous system that happens with a near-death experience that often clients will seek to in some way or another repeat, because a near-death experience can actually have a kind of blissful component to it. And so clients will seek out that state, maybe drawn to doing drugs to find that, or to kind of extreme risk-taking behaviors, or even have multiple near-death type experiences because of those behaviors. And so looking again at a bit of a repetition compulsion inside of those. So continuing to look at our history taking and gathering of information, understanding dissociative symptoms, and this is a very short 5-question assessment for dissociation. It's adapted from the dissociative experiences scale, and typically if you just start with these 5 questions, the very basic of, do you find yourself staring into space and thinking of nothing? Can anyone not say yes to that one? But more so, do you ever feel like you're acting differently in one situation versus another, almost like you're 2 different people, or that things, feelings or experiences feel so far away like you're in a fog? Do you get told that you've done something and have no memory of doing it? That's what had happened with this one man, and then they showed him a video of what he was doing, and he said, oh my gosh, I had no idea, I had no memory of that. Right? Do people, objects, the world, sometimes does that feel unreal to you? And if clients are saying yes to this, then I would probably do a more thorough assessment of dissociation. And again, just like the example I shared earlier, we want to listen to our own somatic experience as clinicians to identify maybe what might be not disclosed by a client. I'll give one brief example here. I was working with a woman, and I kept getting so tired every time I worked with her, and it was so evident that didn't matter what time of day I saw her, and it would be at a certain point in the session, and all of a sudden I would just feel like, whoo, this wave of tired. I wanted to yawn. I'm kind of biting my tongue so I'm not yawning in front of her and leaving her feeling like I'm not interested in what she's saying. And finally I was like, this is ridiculous. I need to say something. And I said, I want to share something with you, and I don't want you to I just want to make sure that you don't take this personally. But I'm noticing that I get tired when we're working together, and I want to be really curious about it. Because I have a feeling that this tiredness that's coming on, it's happened enough times and it feels really connected to something about your experience. And I'd love to have your permission to tell you when it happens. Okay, so we get the agreement field. And so then when the tired would show up, I would say, let's pause right here. This is where the tired is showing up for me. What are you noticing? Right? And then again, she would say something similar to what the other guy said. She said, how did you know? I said, well, what are you noticing? And she said, it's like all of a sudden I just feel like I go into this fog. Okay. Let's really break this down. So it sounds like there might be some dissociation. What were you thinking about right before the fog? Or let's trace back to what were we just talking about? And the fog was connected to an early childhood experience. Her parents had had foster children in the home, and there was this point at which she became the good girl because she knew that the little sister that they had taken in for foster care really needed mom's attention, and that she just accepted that she wasn't going to get it. And so the good girl part would take over, and the part of her that really wanted mom's attention, that really needed mom's attention, would go away. And that was when the fog would take over. And so we were basically reclaiming that part of her through the work by not overriding that moment of tired. And so we have to use ourselves as part of the assessment as well. And that requires our own somatic awareness in the process. How are you guys doing? It's okay? Yeah, good. You're a little tired. I know. Don't dissociate. We have just half an hour. Half an hour more. Stay with me. Okay. Thank you. So another assessment tool here, because our ACEs are so connected to chronic pain, to chronic illness conditions, is we want to understand that. We want to know who's in the room, what are the full range of symptoms that are coming into the room. And so again, we can start to look at current and historical medical diagnoses, current physical injuries, historical injuries, How well is pain being controlled right now? How is pain being controlled right now? All right. Other medications, how do you feel about your body, right? Do you have a history of invasive medical procedures? Have you experienced poor medication management, poor medical experiences, right? Those themselves can actually add to the trauma picture. How about barriers to access of medical care at any phase of one's life? Again, another social factor in all of this. And maybe even understanding family medical history, because that might be part of an important picture here. Were your medical needs attended to as a child? And what were the models that you had of self-care in your family? Social and cultural history questions. Let's go to the next one here. So some other ways, and again, would this be a very long intake to ask all of these questions at once? Oh yeah, that's why we take time and over time, but really holding all of these layers so that our preparation phase, our stabilization and safety phase, stage 1, can take a while. And for those of you that only get 3-5 days with a client, you might just be focusing on one piece, or you might not really do this history taking in depth, but you might be focusing on more of resource development, which we'll get into. Social and cultural history. How do you identify yourself socially or culturally? What aspects of your culture are most important to you? We might find some resources in there. Are there any aspects of your culture that you dislike or that you feel like you have to hide in particular places, right? Do you ever feel discriminated against, harassed, or bullied? Do you or any members of your family, have you ever experienced traumatic events related to your social or cultural identity? This can be war, displacement, refugee experience, fear of deportation, discriminatory experience, and again, holding the whole person in the room. Yes, please.
I've been very aware in my family that my father and his family were immigrants, and the way my father and his siblings integrated into an American community and became Americans created a big change between them and their parents, and also the way we were related to. I didn't know my dad spoke Russian until I was nearly 40 years old.
Wow, that's a fascinating story. I'll repeat it for those that can't hear, is that your own experience of coming from an immigrant family, and how in this particular case, how the assimilation into being an American led to a rejection of the immigration. And this is very common to the other cultural experience, to the point at which the language, in this case Russian, you didn't even know your father spoke Russian until you were 40 years old. And it's interesting, I have my mother-in-law living with us right now. She has moderate Alzheimer's, and she lives in our home, and again my children live with us, so we have a 3-generation home right now. And she has a similar story. Her family came over from Sweden, and she said that very purposefully they didn't teach her and her siblings Swedish, even though her parents and her grandparents, who lived in her home, that was a 3-generation home, all spoke Swedish. Why didn't they teach it? Because that way they could talk about things that the kids didn't understand. But I think that component, again, of being then so far removed and distanced from the family history that preceded you, and I really think that in this culture, although it often gets denied, we're all immigrants of one kind or another, and what? And in this country, and that to take ownership of our own transgenerational immigration histories. And I'm a Jewish woman, and as a Jewish woman, there's huge tales of anxiety in my family history, and so I have had to work with the impact of my own anxiety that was really handed on to me as a legacy. And probably wouldn't know this, but I had tremendous anxiety as a public speaker. And had to work with that. I can say that the work works. I'm grateful for that. But understanding someone within the context of their cultural history, and it leads us right into where we're going here, which is the transgenerational themes of the way that unresolved trauma of one generation then can become a legacy that's passed down to the next generation until someone else is able to feel and heal the loss. Right? And I think that the individual who is most vulnerable, who feels that trauma, the impact of that trauma, is also a strength for the whole lineage, because they become the point at which intervention can happen and healing can start to take place. And it's a very powerful, ultimately can be rolled over into an empowered role rather than a disempowered traumatization. So again, trauma can be passed on when parents reenact attachment dynamics or trauma dynamics that evoke emotional responses in children. And we can reflect on these transgenerational themes. In some cases, the trauma gets passed on because a family member is repeating the story so much so that it becomes part of the family experience. In some families, the traumatic experience is passed on because the trauma is held in silence. Nobody talks about the secret. Right? And yet the child who's sensitive and sees the expression on Aunt Edna's face, excuse me if there's an Edna in the room, or so-and-so's face, and goes, well, gosh, why does she always look so grumpy? Right? But if nobody talks about it, it kind of just gets lodged in there. There's no way to process it. And so we want to find that sweet spot where it's not over passed on, well, it's always like this, and when I was a child, and so forth and so on, or it's also not held in secret. So I personally like to use a genogram to look at those transgenerational themes. I'm seeing a few nods in the room. If you're familiar with a genogram, great, and we'll review it a little bit here. If you're not, it's a wonderful tool. And it helps us address themes like role reversals. And again, we're going to engage embodied awareness of felt experience. So we'll look at a genogram here. This is someone who we'll call Kathy. And Kathy, grandmother, let's back out here. So Kathy was depressed. She was struggling in her relationship with her husband. She had feelings of inadequacy that were coming up as she was parenting her now 2-year-old. So she's a relatively new mother, and she just had a lot of insecurity that was coming up, and it was impacting her co-parenting relationship with her husband, and so she came into therapy. She had some unresolved feelings about her relationship with her mother. She described her mother as critical and cold, and she really never was able to confront her mother. She said that if she confronted her mother with any anger, that her mother either just got angrier or colder, so there was really no repair, no resolution to that attachment dynamic. And so Kathy did say, though, that she had a resource in her relationship with her maternal grandmother. So if you look at the yellow there, the relationship with grandmother was a resource for Kathy, but grandmother, as you can see by the red line there, had a conflictual relationship with her own daughter. So this resource skipped a generation, which is not uncommon, right? And but that she also observed in her grandmother that her grandmother had a certain stoic approach. She was distant, not cold towards Kathy, but had a certain kind of coldness to her. And as we continued to explore this further, we learned that Kathy's grandmother had lost her grandparents in a car accident when she was 5. So Kathy's grandmother experienced a significant loss, and we can extrapolate here that may have played a role in the grandmother's relationship to her own daughter. Okay? So in this case, the grandmother has post-traumatic experience that perhaps went unresolved and now is traveling through a lineage. And so there were themes that then became visible across generations, which were interpersonal conflict and attachment injury and some verbal abuse. Kathy also had a resource in her father who was very caring and still had a caring relationship with him now, and her parents had been divorced. You can see that there's also conflict between Kathy and her own husband, but Kathy's daughter is also a resource. So Kathy identified beliefs of not being good enough and feeling that there was something wrong with her. As we continued to work together, she began to explore her feelings about her great-grandparents' death. Now, great-grandparents are kind of up at the top, above the people that we see here. And but how she imagined this would have impacted her grandmother. Now, this is in her mind. At this point, the grandmother was no longer living, but she shared that when her grandmother told the story, she always shared it as an accounting of an event, like it was detached and unexpressive, right? But this time, when Kathy started to tell the story about the loss of her great-grandparents and the impact on her grandmother, she started to cry. She felt that pain of what she imagined, because of course she loved her grandmother. They had a connection, and she felt this deep empathy for what she imagined it would have been like for her grandmother to lose her parents, both at once, right? And as she told the story and talked about how they had suddenly been killed, she had this deep sadness. She wept compassionately, and she described for the first time feeling empathy for her mother. So all of a sudden, this empathy traveled to her mother, who she's thinking, my goodness, my mother was raised by my grandmother who had all of this trauma and didn't know how to really care for her. And how her mother grew up with her grandmother's unexpressed grief. So there was this real depth of empathy that opened up. And at this point in her own healing journey, Kathy saw her relationship with her mother in a new light. She had this profound understanding that took place within her, and it started to pave this path for forgiveness. She said, "It isn't my fault. It isn't my mother's fault. We are both reckoning with a story that's bigger than us." When she came back the next session, she shared about what it felt like in relationship to her own daughter, right? And she said that she could feel this connection at a new level where she was able to really bond and connect and see her daughter, and no longer felt like she was repeating a pattern that she had learned inside of her. So it really passed through, in this case now, 5 generations, that she became the kind of access point to unwind across both past and future. I'm seeing some nods in the room. If any of you had some of those moments, either in your own experience or with clients, yeah. It's very powerful. Please.
I find doing a visual genogram in front of the client.
Yes.
And having them answer random questions, you find out transgeneral information, and also, as you're saying, you find out where trauma has happened, and they never have spoken about it before or put it together.
Yes. Yes. So I'll just repeat that doing the genogram with the client, creating it together, it becomes a relational exchange as well as kind of gathering information. So, this is in many ways a very simplified genogram for the purpose of offering it for a presentation. Sometimes they are very, very complex. And you can start to talk about themes across generations. I remember one client in particular where where she herself experienced incest. Unfortunately, her daughter had also experienced incest from a cousin. And but then when we looked back, the incest traveled across generations of her family, and this, kind of profound recognition of how incredibly big this was. And again, to see oneself in the context, not for the purpose of feeling helpless, but for the purpose of going, oh my gosh, like it isn't really all just me. So that personalization becomes a broader statement. So we're going to speak a little bit here about where are we going here? We're going to actually do an experiential. So just one last piece here about transgenerational trauma. Again, it's going to be carried in families until someone is ready to feel it. We do not heal the wounds by carrying them for our families. We heal them by releasing them for ourselves. And I think that that is sometimes a really important juncture in this process of healing, is that there is this feeling of, if I don't continue to carry the weight of this wound, I'm betraying my family. This is my duty to my family to continue to hold this wound. And to really have permission to not carry this is huge. It's huge, and it can, again, stand up against messages that have been carried for many generations, and so sometimes you have to really work with that. And some of the literature out there by Bert Hellinger, who is a German psychologist who studied in Africa, actually with, I think, I want to say Zulu, but I'd have to go double check that. But anyhow, he studied about kind of transgenerational work in that light, and really creates these constellations in the room where you can physically mark different people in different places in the room as a way to access that transgenerational weight of trauma and to unwind it. It's very powerful work. So before we end today, we have just about 15 minutes. We're going to do a very brief experiential, and we'll open it up for discussion and questions. So the experiential is on this practice of containment. And as we've already spoken about, loss of choice is a key component of trauma. This includes the choice about where and when to feel and think about the traumatic memory. Because a lot of clients come in and they're thinking about their traumatic material all the time. And so that permission to put it away in a way that's very different from dissociation, right? Dissociation is containment in an unconscious form that's either putting it away into the body through somatization, or that's putting it away by having to separate from self and feeling disconnected and compartmentalized. Containment is conscious compartmentalization, and the reason why it works is because we make an agreement that we're going to come back to whatever the traumatic material is that we're placing in the container, that we're going to come back and attend to that at right place, right time, with sufficient resource. And for the clients who are basically laying out their traumatic material wherever, whenever, and often getting rejected for it, often being told they're too much, or in some way or another recapitulating the traumatic material, this is an instrumental, incredibly valuable trauma treatment practice. So I'm going to invite you to try it for a moment. And you can contain today if this was traumatic. Just kidding. But you can bring something to mind that you would like to be able to contain. Whether this is a recent disturbing event, whether it's something from your own childhood, because the honest truth is that talking about this material can touch off feelings for any of us, and so you might want to take time to make an agreement with yourself that you'll put some of that material into a container and attend to it when you've got the right amount of support. And then I'm going to invite you to bring to mind an image of something that would be able to contain any or all of the difficult memories and feelings that you might be having. I'll give a few examples here. Sometimes people like to use a box, a treasure chest with a lock, a closet that can be closed, a cave with a rock that can be slid in front of it. You get to choose. Importantly, I want you to take notice of how your container opens and closes. I want you to also take note that when you close your container, that it can remain tightly sealed until you choose to open it. And importantly, your container can only be opened by you. So when you feel ready, I'd like you to think of what it is that you'd like to place in your container and to go ahead and place it in there. Again, it can be a worry, a difficult thought. Even you can do this with something from your to-do list that's interfering with your ability to sleep at night. I use containment before I go to sleep often. And then imagine opening your container, placing the thought or feeling or event into it. And once it is inside, closing your container firmly. Taking a moment now to imagine your sealed and secure container. And notice how you feel in your body, having set aside any distressing memory or feeling. If you feel like something didn't make its way all the way into the container, you get to repeat the process. Open it up, put it in there. Sometimes you might notice that you need a little bit more support because things want to pop out of the container. That happens. And so you can put a lock on it or have a protector that helps prevent anything from leaving. It's your imagination. You get to be real creative here. And again, once you have your disturbance placed in your container, notice the sensations in your body. Perhaps you notice some relief. Notice your breath. And notice the quality of your thoughts. And you might also take a final moment here to make an agreement about the right place, the right time, that you would like to reopen your container and address whatever you placed in there. I'll share here that this is also a really great practice for us as therapists to place client material that stirred something up or evoked some feelings in you. You can place client material in a container and make an agreement to bring it back out when you go to supervision, right? So that you have right place, right time, and you're not bringing it home with you after work, and you're not letting it interfere how you're sleeping at night, right? So really good practice for self-care for us as therapists as well. So, how was the containment practice for you? Is this something that some of you already practice? Does it feel new? Could you imagine using this with clients? Yeah? Yeah. We have about 8 more minutes, and that is the teaching material that I have for today, but we're not quite ready to leave yet. We go until 4, and it's strict, so let's use our time. How would you, what questions are lingering? What thoughts about applying this?
I fear that in talking about patients, because I work in an inpatient hospital like the gentleman over there, I'm going to ask the wrong question and then have somebody melt down. So, when did you break your leg? And then bam!
Good. Let me repeat that. So there can be a fear that comes up that when working with in crisis, when the emphasis is stabilization, or inpatient and the emphasis is stabilization, that somehow or another you're going to open them up, uncontain them, and lead them to fall apart more, right? Better that happens in inpatient than out, than once they leave, right? Oh, and we've got 4 questions from the webcast community. Good, great. I'll make sure we get those too. Thank you so much. So honestly, I do want to say that, like, if it's that delicate, better that it happens there. And because at least you're going to get more information about what triggers them and what leads them to feel, leads to that kind of instability, that falling apart. It doesn't mean you're going to work with the traumatic memories that might come up in that moment, but you might tag them and say, you know what, we're going to get you stabilized, and I'm going to give you, I'm going to put this in your notes so that when we transfer you to your outpatient therapist, this is some stuff that you can work on there. Okay, I'm going to address the questions from our webcast folks, and then we'll come up back to what's in the room. So from Tricia Gonzalez, can you make a statement about complex PTSD and psychosis? So yes, I can. Great question. And I think the short answer to this is that there can be some comorbidity, but I think we also want to recognize that psychosis can be a symptom related to a lot of different disorders. And that kind of moment where reality gets diffuse and where it leads to the level of instability that then leads someone to hear voices, see things, have such intrusive flashbacks that it's impairing the ability to know what's real and what's not real, what's now, what's then. It's often a preceding factor to why someone goes to an inpatient facility or starts to feel like they're quote-unquote crazy. And I think very often gets addressed through medication or psychopharmacology when ultimately we want to see if we can slow that process down and see if we can understand what might be happening that might be trauma related as we do a really good history taking. So a brief example here is a woman that came in with a somatic experience, like there were bugs crawling all over her, and to the point where she felt like she was going crazy. And as we worked with it, the experience of the childhood trauma had a lot of parallel themes to that feeling of I'm being invaded and I can't control this. And so sometimes what shows up in the psychotic symptom can have kind of parallels or metaphors for what the traumatic experience felt like. So Tricia, hopefully I'm addressing your question there. In regards to preventing re-traumatization, is estrangement appropriate for adult children and their abusive parents? Good question. And to what degree does CPTSD sufferers self-protect from sources of their trauma? Well, that's such an individual question. I have certainly had clients that have chose to completely sever relationships with members of their family of origin because there was so much re-traumatization that happened upon any reunion, any reconnection with family members. And also there have been times where clients have chosen to stay in and to do a lot of resourcing. So one woman comes to mind who we had to make really firm agreements that even though she wanted to go back and visit her mother, she wouldn't stay at her mother's house, right? That was too much, that she would go and visit mom not at the house because that was too re-traumatizing and she would dissociate, so she would only go see her for 1 hour at a restaurant, right? And that there were very, very clear boundaries that facilitated a reconnection with in this case, again, the source of their trauma, but allowed her to not dissociate. And for clients that can't go back home without dissociating, then sometimes, at least for a period of time until there is greater stabilization, they need to cut off. And it's not for me to say what's right or wrong. It's really a collaborative experience of working with the individual. Next question, and I'm going to just cover up these two. So if there's two more questions here, if you guys have other questions, save them for tomorrow, okay? We'll do these real quickly. From Michelle Hart, I'm curious about the presentation of complex PTSD in male versus female genders. Are there different comorbid symptoms, different personality disorders that you see more often, like I'm adding this to the question, like are women more prone to borderline and men more prone to narcissism? And different behaviors and symptoms in general. It's a great question. I don't know that I can speak to it from a research angle. There probably are differences in, again, we know there's differences in how the brain experiences early childhood trauma, and there probably are differences in the expression of this symptomatically, and I'm probably not going to do a good enough job to answer that question in the time we have. Next question, again from Tricia. In other words, what if the past is not over and the person continues to feel traumatized because they are still in relationship with traumatizing people? This goes back to that other question, the adult child and the parent. So I think I addressed that one well enough, and Tricia, you can send back the question tomorrow if we didn't get to it. All right, you guys, it's 3:59. We did it. Woohoo! I will see you bright and early at 8 o'clock tomorrow. Yes. And we'll cover lots of tools and interventions. Looking forward to it.